بسم الله الرحمن الرحيم. أبنائي الطلبة الأعزاء، السلام عليكم ورحمة الله وبركاته. راح نبدأ وياكم اليوم محاضرات الكورس الثاني بالسيرجري، ومثل ما تعودنا المحاضرة راح تجيكم على شكل تسجيل، وراح تجيكم على شكل وورد. انتم مطلوب منكم الوورد، والتسجيل هو للتوضيح. المحاضرة الأولى قسمناها إلى قسمين حتى سهولة عليكم انه تحملوها. We start with introduction, surgical prophylaxis, antibiotic administered before contamination to prevent an infection from developing. The common surgical pathogens in clean procedures, skin flora including the staph aureus and staph epidermidis. In clean contaminated procedures, gram-negative rods and enterococci and skin flora. Antimicrobial selection. How to select the antimicrobial agent? Depend on the type of procedure, most likely pathogens, safety and efficacy of antimicrobial. Gram-negative coverage is included because of staph aureus and staph epidermidis are common in skin flora. Parenteral antibiotic is favored because they achieve a suitable tissue concentration. We preferred the parenteral antibiotic rather than oral antibiotic. First generation cephalosporin, which is the cefazolin, are preferred for clean surgical procedure. An anti-anaerobic cephalosporin like cefoxetine and cefotetan are used for broad spectrum anaerobic and gram-negative coverage. Vancomycin is used in implantation of a prosthetic device surgery as MRSA is high, which is MRSA is methicillin resistant staph aureus. If risk of MRSA is low and hypersensitivity to beta-lactam, a clindamycin is used instead of cefazolin. Types of surgical operations. We have the surgery, surgical infection risk, and antibiotic. In clean surgery, low risk and antibiotic not indicated unless high risk procedure. In clean contaminated surgery, medium risk medium and prophylactic antibiotic is indicated. In contaminated, the risk is high, so prophylactic antibiotic is indicated. In dirty procedure, the risk is very high. It is from the start it's infected surgery, so therapeutic antibiotic is required. Okay. The principles of antimicrobial prophylaxis. The first is the route of administration. IV route is preferred as gives a more reliable and predictable serum and tissue concentration than IM route. Oral route is used in some bowel operations. Non-absorbable compound like erythromycin base and neomycin are given up to 24 hours prior to the surgery to decrease the microbial concentration in the bowel. oral agents are used adjunctly and don't replace the IV agent. يعني we don't replace IV agent by oral agent because the IV routes, as we say, it is a more reliable and more predictable serum tissue concentration than other routes. Timing of the first dose. Correct timing is vital to allow therapeutic concentration in the blood and wound tissue during the operation. So we must give the antibiotic in a precise time. The National Surgical Infection Prevention Project, NISP, recommended the using of antimicrobial within 1 hour before the first incision. Before the start, 1 hour before the start, we must give antimicrobial agent, except fluoroquinolones and vancomycin, where they are given 2 hours before surgery to avoid infusion-related reactions. Beginning after the first incision is of a little value to prevent surgical infection. Okay? Dosing and redosing. This depends on half-life time of antimicrobial agent and the duration of the operation. The goal of dosing is to maintain the antibiotic concentration above the MIC of suspected organism during the operation. If an operation exceeds 2 half-lives of the selected antibiotic, then another dose is given. If long operation more than 2 half-life time, we must give another dose, a duration of the dose. Continuation of antibiotic after wound closure is unnecessary. The duration should not exceed 24 hours and we must exceed 48 hours for cardiac surgery. In any surgery must not exceed 24 hours, but in cardiac surgery must exceed 24 hours. Combination of antimicrobial therapy used to broaden the spectrum of coverage and give synergistic activity and prevent resistance. يعني أننا نستخدم الكومباينيشن حتى يوسع لي الطيف ويكون synergistic activity and prevent the resistance. Increased antibiotic coverage is necessary in mixed infections such as intra-abdominal, nosocomial, and female pelvic infection, in which a variety of aerobic and anaerobic bacteria. This advantage of combination increase the cost, increase the risk of toxicity, super infection with more resistant bacteria. The another subject is thromboprophylaxis. DVT is common in patients over 4 years with a major surgery because of post-operative increase in platelet with venous endothelial trauma and stasis of blood. Without prophylaxis, 30% of the patient will develop DVT and 0.1 to 0.2% die from PET, pulmonary thromboembolism. Types of thromboprophylactic: mechanical devices like TEEDs, thromboembolic deterrent stocking, drugs like heparin and low molecular weight heparin. The regime: heparin 5,000 units subcutaneously 2 hours pre-operatively, then every 8 to 12 hours subcutaneously for 7 days or until ambulant. Low molecular weight heparin like enoxaparin 20 mg per 24 hours subcutaneously and can increase to 40 milligrams for high risk patient starting 12 hours pre-operatively. Fondapyrinox, which is a factor 10 inhibitor, decrease the risk of DVT over low molecular weight without increase the risk of bleeding. Risk groups. We have the procedure factors like prolonged anesthetic time, prolonged procedure, low limb and or pelvic surgery are more risk. Patient factor like immobility, مقعد, malignancy, dehydration, age, obesity, diabetes, cardiorespiratory diseases, inflammatory pathogens, oral contraceptive pills, hormonal replacement therapy, past or family history of thromboembolic disease. These the risk balanced against the bleeding risk like active bleeding. يعني احنا لازم نوازن بين الريسك of thromboembolism and the bleeding risk. Active bleeding, stroke, invasive procedure, bleeding disorder like liver disease, thrombocytopenia and inherited disorder. The other one is the risk of compression device peripheral vascular diseases. Thank you. This is the first part and we have the second part of the first lecture. Thank you.